Hi, welcome. Okay, well, let's go ahead and get started. It looks like there's a good number of people here. So thank you all for joining us this evening or whatever time it is in your time zone. My name is Ellen Hostetler, and I'm the Chief Science Officer for the John Ritter Foundation for Aortic Health. And we have been supporting the research efforts of Dr. Milewicz and Dr. Murdoch and their team at UT Health as they relate to smooth muscle dysfunction syndrome for many years now. So I'm pleased to have them provide an update on their work and efforts on this condition. And I'm not going to say much today because I know there's a lot of great content that they want to update you on. But I just want to thank them both for being here and in the evening too, as it is for them, I know, and sharing their expertise with us. So Dr. Milewicz is the President George H.W. Bush Chair of Cardiovascular Medicine. It's always a mouthful for me to get that out correctly, but I think I did it. And she's also the director of the Division of Medical Genetics at the University of Texas Health Science Center in Houston. She's the chair of the Professional Advisory Board for the John Ritter Foundation for Aortic Health, and also a board member since the inception, I believe. And she is a physician researcher who has spent her entire career working on the aortopathy or genetics of aortopathy. And she's also the person who first discovered ACTA2 as a cause of genetic aortic disease, and also SMDS and the genetic cause of it. And so I will turn it over to her. And then we also have Dr. Murdoch here, who is a geneticist who works with Dr. Milewicz and the team and has really led a lot of the work on this trial that we're going to talk about today. So thank you for your hard work on that. And with that, please feel free to ask questions in the chat or the Q&A. I will do my best to answer them and to flag them as we go on.
Yeah, thank you for that nice introduction, Ellen. Do I have to share my screen again?
You do, I'm sorry. Yes, you will have to click that green square.
Got it. Good evening, everybody. Thank you for joining us. We're going to be talking about the background data that led us to a clinical trial for SMDS, and I will go through the background data that we did in the laboratory and how we came to identify nicotinamide riboside as a possible drug that could prevent at least the cerebral vascular complications or the problems with the arteries in the brain in patients with smooth muscle dysfunction syndrome. And then I'll also talk about what implication it has for other patients with moya disease. Then I'll turn it over to David to update you on where we are with the clinical trial. So I'm going to go ahead and get started. Everybody here knows that SMDS is due to alteration in a gene called ACTA2, and it's a specific change that alters one amino acid called arginine 179. And we already, listed the complications that these patients have, but really the most serious complications are here on the slide. And it includes, hold on just a second, the cerebral vascular disease, where the large arteries in the brain become occluded, and it's the part of the artery where it goes from the outside of the brain into the interior of the brain is called the distal internal carotid artery. Another feature that led me to identify SMDS was the fact that the patients have aortic disease. And the good thing about aortic disease is we know how to manage it. When somebody is diagnosed with SMDS, we know we have to watch the aorta. We can watch it grow to a certain size, but ultimately we need to go in and put in man-made material to replace the aorta. And that's really to prevent this end of the disease spectrum, those dissections, which can be deadly. And so if you're being followed and they're watching the size of your aorta and they have you on either losartan or beta blockers to sort of decrease how much force there is on your aorta, you should and they should be watching for an aneurysm or enlargement and then going in and repairing it. And if they do that, they completely prevent these deadly dissections. So that's the good news. And then finally, there is a pulmonary problem, and we've really, I've switched the attention in my research program. We still are working on the cerebral vascular disease, but we really need to understand the lung disease better, because so many people end up getting into lung problems, pretty serious lung problems when they get older. I think the vast majority of children are on some drugs for pulmonary or lung breathing problems, and it just gets worse as it gets older. So we need to know how to treat that better. And even starting in childhood, make sure we protect the lungs, almost like they do with children with cystic fibrosis. So this brings up most of these things show up when a patient with SMDS is very young. And so if you could fill in the age that your loved one, your family member was diagnosed, we can do another survey here. So I know, or you yourself was diagnosed with SMDS. Ellen, let me know when the results are there. So it looks about like a quarter of you were of the affected individuals were diagnosed at birth or under 12 months of age. Another 30% were diagnosed under the age of 3. And the rest of them were diagnosed at older ages, including 25% over the age of 18. So there's a really more of a spread than I thought. I thought most people would be diagnosed at a much younger age. So, and what complications have you or your family member with SMDS had? Oh, I think we already did this one, didn't we? Yes, we did. Okay, so we have these different complications, and what I'm going to talk to you today about is those that involve the cerebral vascular arteries. And like I said, they end up getting blocked and in what's called a moya-moya-like pattern. And this really shows you what we think is going on and have a lot of data to support this hypothesis. Over here is a healthy artery, and your artery has 3 layers, one inner layer of what's called endothelial cells, a layer of muscle, and specifically smooth muscle shown here, and that's made up of a whole bunch of cells, then an outer layer that's called the adventitia. And so what we think, and have a fair amount of data to support, that what is happening in patients with ACTA2 is that the cells that should stay in this middle layer of the aorta, which is called the media, they actually are changed such that they move more or migrate, and they will migrate into the inside of the artery, and then they begin to grow, almost like a tumor. They start to enlarge, and that's what leads to the occlusion of the arteries in patients with SMDS. And this is just a picture of an artery of a patient with a moya-moya occlusive or block of the internal carotid artery. And this is that layer with the smooth muscle cells are here in the medial layer, which is part of the normal wall. And all the purple marks show an individual cell. And usually you can see the squiggly pink line. And usually within that squiggly pink line, this is completely opened up. There's nothing on the inside. But you can see in this artery that's been closed off due to moya-moya disease that there's a whole bunch of cells as marked by the dark purple stain to the nuclei of the cell. So here you have a lumen where it seems to be filled up with cells and it almost looks like a tumor has formed inside the artery. And when we stain to see where these cells are coming from, they are coming from the cells here in the wall. So once again, just looking at the lesions or the blockage and what's going on there, it really shows that it's primarily the cells coming from the wall of the artery, those smooth muscle cells that are moving into the lumen. And importantly, I named this condition Smooth Muscle Dysfunction Syndrome because with this particular condition, smooth muscle cells are disrupted throughout the body. There's smooth muscle cells in the aorta and they don't work right, and that's why people get the aortic disease. The smooth muscle cells in the gut don't work right, and that's why you've got the problems, moving food through the gut. And then finally, the smooth muscle cells in the bladder don't work, and that's why you end up have problems. That's why affected individuals and children have problems getting all the urine out of their bladder. So this is really another illustration where the smooth muscle cells are defective. They're not staying in the wall where they're supposed to, but instead they're moving inside of the artery and proliferating, and that leads to occlusion of the artery. So to really figure out what's going on, and I'm going to sort of breeze over some of this because it's a lot of very complicated science, and we've been working on this for almost 8 years to figure this out. But what we did was we got skin biopsies from affected patients, and we can turn them into stem cells called induced pluripotent stem cells. And then we can take them into another type of stem cell called neurocrest, and then into smooth muscle cells. And we can look at how cells with that ACTA2 variant are altered in this process versus normal cells. We also made a mouse where we put the mutation into the smooth muscle cells specifically, and we call that our SMDS mouse model. And then we got cells from the aorta, the smooth muscle cells from the arteries of the mouse, but also from patients who had their aorta removed and grew out smooth muscle cells from the artery. So we do all this to be really rigorous in terms of the science we're doing. We want to make sure we can show the same exact defect, no matter where we get the smooth muscle cells from. And importantly, going back to the patients and making sure what we see in our animal models is exactly what we see in the humans. So like I said, it takes a lot of time to set up these studies, and doing them. All the experiments have to be done in triplicate at a minimum. And the mouse studies, you need hundreds of mice sometimes to complete the mouse studies. And I'm really thankful to all the families that have raised money for these studies over the year. So this really summarized what we found. When we got to that stem cell neurocrestal stage, we found cells with the ACTA2 arginine 179 variant that causes SMDS never make it to a completely differentiated smooth muscle cell. But instead, when they have that mutation, they end up with a smooth muscle cell that is immature. It's never fully differentiated. And because of that, it acts like a stem cells. And stem cells are known to be highly migratory. They move around a lot. Even in the dish, they'll move around. And they proliferate like crazy, once again, like a tumor cell. So what we think is going on is that in the SMDS, the cells move into the lumen because they never fully differentiated. And that's the etiology or the cause of the arteries being blocked. And so this begins, we just published this in one of the major cardiovascular journals. And we've gone on to see if we can make can we get the arteries in our mouse model to get blocked and look exactly like the arteries in a patient with moyamoya disease due to an ACTA2 mutation. And so we've looked at the carotid artery in a control mouse and a mouse with SMDS. And what we found, if we just do a minor injury to the artery and wait 3 weeks, this is what the control artery looks like. It looks completely normal. And here's the wall. The purple cells are there showing the smooth muscle cells in the wall. And when you look inside or inside the artery, what we call the lumen, there's nothing in there. And that's where the blood flows. But then you look at our SMDS mouse, and then first of all, the artery is bigger, but then here's the wall way out here. And all of this is complete blockage of the artery with cells. Once again, they stain positive for markers of smooth muscle cells, and they look a lot like the lesions we see in the patients. So for reasons that I don't have time to go through, we wanted to see if we went back to this major problem, could we give the cells and the mice a drug that would actually, instead of the cells ending up over here, they would go more in this direction to a differentiated, contractile, quiescent smooth muscle cell that didn't migrate and proliferate. And so it turned out a nicotinamide riboside was a great drug that worked to prevent this. And we are now working on other drugs that may have the same effect. So we're going to start with nicotinamide riboside because it's a drug that the FDA has already approved for our clinical trials. And it's something that's being used in many, many clinical trials. And because of this reason that here's our control mice and the ACTA2 mice with no nicotinamide riboside. And here's the control mouse with NR. The stuff on the inside is just some junk that got in there when the artery was fixated. It's a little bit of blood that didn't get washed out completely. But here is our ACTA2 mouse on the nicotinamide riboside. And you can see that we've changed the lesions from being completely blocked to being open. The artery is still enlarged, so there's still a little bit bigger than the control artery, but it's completely free of smooth muscle cells. And this quantitates these findings over here. And also our mice, about 20% have strokes, and on NR, there's significantly fewer mice that have strokes. So both the strokes are prevented, the lesions themselves, that blockage, that pathology is blocked. And more recently, we've been doing some behavioral studies, and we can show NR improves the behavior in our mouse after the vascular injury. So this is how we came upon using NR, and I'm using the term NR, but I'm just shortening it for nicotinamide riboside. We've also asked the question, so what about other causes of moyamoya disease? Will it help? And one of the major causes is another mutation in a gene called PCNT. And we've been able to show that it prevents this, the cells have the same defect, and NR actually helps those cells. And then we've also know there's the major cause of moyamoya disease worldwide is a gene called RNF213. We found that there were very severe mutations in this gene that caused childhood onset of moyamoya disease as young as 1 year of age, with the children typically dying 3 to 4 years of age because of progressive moyamoya disease. So we're actually checking to see if it'll work for RNF213. I actually went to the International Pediatric Stroke Organization Congress just a few months ago, about a month ago, that was held in Toronto. It was actually, I landed in a blizzard, if you can believe it. But it cleared up and there was snow on the ground still, but it was nice and sunny for the actual meetings. But they invited me to come up and talk because we don't have a drug to prevent moyamoya disease. And they had been reading our published papers. And we're very interested in helping with the clinical trial for all patients with Moyamoya disease to see if nicotinamide riboside would work. And actually, late last night, I got an email from a pediatric neurologist in outside of Texas in the U.S. who had been at this meeting and heard about our work and had a patient with one of those severe mutations, one of these mutations in this gene, RNF213, that was causing Moyamoya disease. And the child kept on having strokes and they had no treatment for the child. So we helped get the child started on nicotinamide riboside this morning. So they're going to go ahead and start using it for the very severe cases of Moyamoya where they don't have any treatment at all for those children. So we may get information on the usefulness of Moyamoya disease faster through these studies than we do through ACTA-2, but we still would like to launch in the ACTA-2 patients also. So that explains what we're doing for the cerebral vascular disease. We don't understand the pulmonary disease that well. So that's where we're really going to focus in the next few years, is to better understand the pulmonary disease. And there are reasons, multiple reasons, to think NR would improve the pulmonary problems too. And then in terms of the aortic disease, we already have studies from a group in Spain. They gave NR to a mouse model that forms aneurysms due to a different gene mutation. And here's the growth of the aorta without NR in their mouse model. And with NR, really slowed down the growth of the aorta and almost reversed the aorta down to normal size. So that's very encouraging that possibly NR would even help the aorta. So I'm going to come back to this in a minute and have David go ahead. I'm going to let David talk now about the clinical trial.
All right. So yes, I'll spend a little bit of time talking about the clinical trial that the NR clinical trial that our preclinical trial that we've been getting underway. So it really started about a year and a half ago when we started to write the protocols and get the approvals for everything, and so we've been able to to get all of that, and so the study is actually underway now. It's actually, if you want to go to clinicaltrials.gov and read all about it, you can just use the link here at the bottom and the ID. But really everything about the study is there. So and then you can contact us as well. But really the overall goals are number one, to determine whether SMDS patients treated with NR, nicotinamide riboside, exhibit decreased glucose uptake in the aorta. So, and that's using an imaging technique called PET scan, which I'll talk more about in just a bit. But our idea, our hypothesis is that that, like we see in other tissues, that the smooth muscle cells in the aorta have abnormally increased glucose metabolism, but that treating these individuals with NR will lower that, and that we can essentially detect that change using PET scans. We also want to see whether NR treatment results in actual changes of levels of NR and its metabolites in the blood. And so that's something that we can measure with some specialty blood work, but it's basically just blood work. And then third, we want to confirm that the aortic measurements are stable after treatment with NR, and that's using an echo or echocardiography, so just an ultrasound of the heart. And then lastly, we want to evaluate the safety and tolerability of NR in patients with SMDS. And so all the evidence to date shows that it has a very low risk profile. It's very well tolerated, but we just want to make sure by following these patients. And then lastly, we want to collect all of these data so that we can start a full clinical trial for SMDS and potentially other indications, as we've already heard about. So again, why use a PET scan? So you all have probably heard about PET scans in relation to monitoring cancer treatments, and it's kind of the same principle in that you're looking for increased metabolic activity of different tissues. So in cancer, these are very metabolically active cells, but we're using the same kind of imaging technique. But instead of looking at cancer cells, looking at these smooth muscle cells that we believe have also increased metabolism, glucose metabolism. So, so kind of taking a different application, but or a different application of the same underlying technology. So there in the middle, I don't know if you can see it too well, but the black arrows, that's a PET scan, and it's a cross section of the aorta. I don't know if you can see that kind of dark gray or black ring. So that's a cross section of the aorta, and that the kind of dark area is the increased metabolism, glucose metabolism in an individual with SMDS. So on the left, that's just a CAT scan, a CT scan that we use kind of to visualize the structures and to overlay the PET imaging. And there on the right is the actual combined image. And again, the white arrow is pointing to that kind of thin little red ring, which is the area of increased glucose metabolism in the aorta. So, so this is essentially what we're doing. We're using PET imaging kind of as the biomarker to identify increased glucose metabolism in the aorta and to see whether that changes after treatment with NR. So this is an overall kind of outline of our preclinical trial. So our goal is to collect data from 5 SMDS patients. So they all have to have the R179 active 2 pathogenic mutation. The age is from 5 to 18. And really the minimum age is more of based on the the ability of that person to tolerate a PET scan, which takes about an hour and a half. It's important that they have native aorta, so not surgically replaced, because again, we're looking for that abnormal glucose metabolism in the smooth muscle cells of the aorta. So if someone's had it replaced, we wouldn't be able to see that. So, and as I mentioned, they just have to be able to tolerate that PET CT scan. So all the travel and hotel is covered. It can be done pretty quick. 2 days of actual study. So come in on a Sunday and leave on a Wednesday morning. There's no cost associated with it in terms of the imaging, the echo, the labs, and there's no cost for the treatment itself. And so just a quick information about the actual type of NR that we're using. So there's a commercially available version of it called Niagen. It's available over the counter. I think, as we've mentioned before, it's a form of vitamin B3. So this particular form of NR, Niagen, has been used extensively in clinical trials for various conditions, Parkinson's, heart failure, others. It's been used in adults and children. It's very well tolerated at even much higher doses than we're proposing here. We're going to be doing weight-based daily dose for 8 weeks. And as was mentioned before, we did get approval from the FDA for using this Niagen in this study. So so this is kind of the basic breakdown of the trial itself. So on day 1, just some basic labs, CBC, metabolic profile, that kind of specialty test looking at NR and its metabolites. So that will be done on day 1. Then an echo will be done later that day. Very, very easy to do. Again, just an ultrasound of the heart. And then on day 2 is when the actual kind of real meat of the study is being done with the PET CT. And then, patient and their parent can go home. And then 8 weeks later, we'll just repeat the same thing after treatment with the NR for that period. So in terms of a little bit more information about the PET CT scan itself. So so again, the goal is to identify any increased glucose uptake in the aorta at baseline, and then to see if there's any decrease after treatment with NR. Now, understandably, there's some concern about radiation exposure. We do part of it involves a CT scan, but it's actually very low radiation exposure overall. The CT scan is actually it's not like something that you would have done in an emergency room or something. It's really a very low, quick scan just to get some basic structure so that we can overlay the PET imaging. The total amount of time for this is about an hour and a half. Not all of it is actually collecting the images, but an individual essentially should be able to lay flat for about an hour and a half. The day prior to the PET scan, the patient would just have to have a low carb, high fat diet. And then on the day of the scan, which is typically done early in the morning, they just need to be fasting. But then after that, you can eat whatever they want, and actually they'll be done with the study and can go back home. And it only requires a small IV to be placed, really just to administer that glucose tracer, which is what's being detected from the PET scan itself. So I'll just finish off with saying, kind of where we are. So we're actively underway. We hope to have some of our initial data actually just in the next few weeks, but we're looking for additional participants. And as was mentioned before, patients with NMD due to other causes are being started on NR. So we should have a lot of information about NR even outside of ACTA-2 pretty quick. NR is available now. As I mentioned, it's it's over-the-counter supplement. It has been shown to have a very low risk profile. It's been used in many clinical trials and is tolerated very well. So that's very good. We're aware of other studies for SMDS patients, and we plan to coordinate with other investigators on these trials to really ensure that all these patients are eligible for as much as possible. So again, if you are interested in participating in this trial, you can just reach out to us at these email addresses, or go to this website to find out more about the study itself. That's really it.
Great, thank you. That's very exciting just to see that it's enrolling now after all of this effort on your part and both of your parts. I know that you have been working on this for so long. We do have some questions, so feel free to put more in.
Before we get to the questions, I just want to mention, the group in Boston is planning a clinical trial using the CRISPR-Cas editing to go in and correct the mutation. I think their studies are moving along, but it's still going to be a number of years before that is anywhere near clinical trials and anywhere near actually being able to use it to correct the mutation routinely in the clinic. And so I think that is such a promising way to go. But in the meantime, we need to help the patients now. And that's really why we need to get this NR clinical study going now. And we've noticed that some of the patients that have wanted to participate in both were, Boston had indicated to them they didn't want them actually participating in our trial. And I think we just need to sit down with the Boston investigators, Patty Mussolini and Mark Lindsay, to really get this figured out, because I think they're afraid the drug will change the natural history. But the way we treat diseases is we get drugs that work, and then we proceed with trying to improve the care even with that drug. So I don't think having the patients on NR should prevent them from participating in the clinical data that the Boston group is already trying to collect. I think we just need to work it out. And I think somebody posted something in the chat. I didn't see that.
Yeah,
about
it
another
disappeared.
investigator that is working with.
Yeah, it disappeared though. I didn't even know you could delete a chat, but yeah, it's gone now. um,
it's a ghost chat.
a ghost chat. And conceivably, as you said, this drug is available. You could go on Amazon and probably buy this right now.
Oh yeah, no problem.
Correct.
You could get it and start it yourself. We'll give you the dosing for children. But we would prefer to collect the data going forward. And the reason we're starting with the preclinical study is we just want, before we start the full clinical trial, we want some indication that NR is actually working in the patients. And we want to have a marker to say that it's working. And that just helps so much to be certain that what we're doing is correcting the underlying defect in humans. We've got all this mouse data, but we really need to make sure it's working in the patients themselves.
Mm-hmm. Okay, let's do some of these questions. The first one asked, why do the other ACT2 mutations not have problems in all of their smooth muscle cells?
So that's really was explained in that Nature cardiovascular research paper. For some reason, this particular ACT2 179 and one other mutation we looked at, ACT2 258, those are the two recurrent mutations with the patients have Moya disease. And we now know both group of patients have problems with the lung disease too.
Mm-hmm.
And so there seems to be an overlap, but the 258 is a later onset than the SMDS mutation, the 179. And the reason is because you're disrupting a very specific function of the ACT2 protein in the cells. And it's very complicated, and it took us like 5 years to get this figured out and really prove it scientifically. But the protein, which is thought to just help the smooth muscle cells contract properly, is actually moving into the nucleus and helping the cells differentiate. It was a completely new function, and the 179 and 258 prevent that movement into the nucleus, and that's what disrupts the differentiation, and that's why it never gets fully to a smooth muscle cell from a stem cell. It's like if you had a baby that didn't grow and stayed a baby. That's the problem.
And if you would like to read the very, very complicated paper, we'd be happy to share it with you.
Yes.
It has many beautiful figures that I can only imagine took years to create of work.
Lots of Kelly's sweat. She was
yes,
the
indeed.
postdoc in my lab working on
that. Okay, would this drug affect other cells that aren't smooth muscle cells? Would those other cells turn into smooth muscle cells also?
I think that it can have an effect on any cells, but what it does is boost a certain type of generation of energy by the cells. So it should just help all the cells, but it's not going to make them differentiate into a cell type that they're not supposed to be. So, yeah. So the thing about the problem with the ACT2 mutant cells is that they do turn on a little bit of the smooth muscle cell marker. They just don't really go all the way. And so they still are partially smooth muscle cells. This just gives them a push.
Okay. And I believe this, people use this supplement as kind of a
energy booster.
Yeah, anti-aging.
Yeah. Whether, I don't know if it has any proof that it works in that way, but people use it who are not sick for a positive because they believe it as a
because they think
thing
it's going to make them healthier.
Okay. Why doesn't the aorta get filled up with multiplying cells the way that the brain arteries do?
That's a great question. It actually does get filled with cells, but the aorta is really has a big lumen, so it doesn't get blocked, but cells do end up inside the lumen. And we actually know from both our mouse model and from humans that just about every artery in the body has some smooth muscle cells in the lumen in patients with SMDS. Whereas if you look at people that are age matched, the vast majority of the arteries don't have any smooth muscle cells inside the lumen. And so it's happening in all the cells. For some reason, it ends up being much more prominent in the cerebral vascular system, but SMDS patients have problem with occlusion of the arteries in their arms and their legs and elsewhere. It's not all patients, but a rare patient will have an occlusion or blockage of another artery. Probably the same process is going on there.
Does NR reverse existing occlusions?
That's a great question. That is an experiment that is going on at this moment in my lab. In fact, we have the mice ready to go, and I think they were actually underwent the minor injury of the carotid artery just last Friday. So we're going to let the lesions form, and then give a group of mice NR and give another group not give them NR, and then look at the lesions a few weeks later.
Are NR trials for adults with moya-moya-like occlusion with active 2, but not R179 any? Oh, I think this is similar to what you mentioned with the arginine 258. Someone else further down mentioned arginine 212. I think
that one we don't think causes problems with more. There's a few other mutations that we have identified moya-moya disease in those patients, but it's just usually a solo patient, and we haven't had like a second patient to confirm it. But so arginine 179 and 258 are the two. The two where we really see the problem with the cells and the problem with the protein moving into that nucleus.
And regarding adults, for this trial, given that they need to have native aortas, that would preclude probably most adults living with SMDS, yeah. But is there potential, outside of this trial where this drug treatment to work, that NR could help adults as well?
I'll let David take this question.
Yeah. I mean, we're trying to get this, initial data using the PET scans and all that, but our goal is to eventually, design a full clinical trial that is basically expands the eligibility, so that we're no longer requiring that someone have their native aorta. Because really, we want to, like Dr. Milewicz mentioned, have this clinical trial to show that we can see the decrease in glucose, abnormal glucose metabolism with NR, so that we can take that information and then design a full clinical trial for SMDS and other indications with expanded eligibility criteria. So it's coming. But we need this data first.
Along those lines, David, maybe these two are for you too. What are some of the side effects that you found so far, or that people could expect? And is this a one-time treatment or something you would need to be on lifelong?
Right. So the side effects, as I mentioned, NR or Niagen specifically has been used in many clinical trials, and overall it's been very well tolerated. Most trials don't even mention anyone having any problems or side effects. There have been a few reports of some very mild side effects, nausea, headache, indigestion, things like that, but they're not permanent. They're not they don't carry on for a long time, and so pretty typical of any kind of, even like placebo type things. Some people will always report some mild side effects. So it's very well tolerated, and even at higher doses, as I mentioned before. In terms of length of treatment, so our trial is just for 8 weeks, but in we would think that if it's beneficial, someone would need to be on it for the rest of their life to so that they don't revert and because that you're not fixing the underlying uh, issue. It's kind of finding a way around that. So that would require lifelong treatment. But fortunately, it's fairly inexpensive, and and it's been studied for a long time. It's but it would be a lifelong treatment.
We are having a lot of action in the chat, so I'm moving over there. Let's see. It looks like someone has shared the name, the ghost comment we saw of a researcher or physician at Cleveland Clinic who is interested in working on this condition. Is it worth it to start NR if I've already had my ascending aorta replaced but have aneurysms in other portions? Descending aorta and aortic root.
So this is someone who's already had surgery. Is it worth it? I mean, I will say, we've had people reach out to us and kind of in similar situations, and due to its low risk profile, we have said it may be worth considering. So personally, I mean, I think yes, but everything, case by case basis, and but we think it could help.
Yeah, I think if somebody's had their ascending aorta repaired, that's really good. And they need to watch the other aneurysms involving the aorta or other arteries. And we don't think that NR will reverse those or anything, but NR can still help prevent progression of additional blockage of the arteries in the brain, at least potentially do that. And then, like I said, there's reasons to think that NR would help the lung disease too. So when we set up the full clinical trial, we'll also be looking at lung disease and getting data on how well the lungs are functioning.
And if you were going to go that route, should that person ensure that they're in your registry so that
yes, that would be fantastic. Yeah, we've had a registry of SMDS patients since I identified and described the syndrome, and we actually use that to write the first treatment guidelines for the syndrome, and we did publish that around 2014 or 2015. And I can't tell you how many people have thanked me for having that information in terms of helping them, their doctors know how to treat this condition. And we want to continue to put people in our patient registry so we can turn to them when it comes time for the clinical trial. Like I said, we also want to work with the researchers in Boston to make sure that anybody that's in their registry also has the option, but this is something we need to discuss with them. I think we're ready to go with the trial. And like I said, it's going to be quite a few years, at least 2 or more, if not longer, before they're ready for a clinical trial using CRISPR-Cas editing. And so in the meantime, let's get going and see what we can do to improve outcomes with this disease now.
The same email address that Dr. Murdoch showed, the mac@UTH, is a great email to you if you are not already, or your child is not in the registry. Reach out to that and they will get you sorted. And it's all virtual and you don't have to go anywhere to be in the registry or do anything. You can do it all from home. It's just access of medical records.
And just to remind you, for this first preclinical study of the PET imaging, we cover all the costs of everything. So you shouldn't have any out-of-pocket costs. The one thing, just because the funds are limited, we will pay for one family member to come with the patient, no matter the age of the patient. I think you always need that support. And if you really need two family members there, we could see if we could swing it. And I really want to thank some of the people that are on the call for supporting this research. I know that and if they want to pipe up and say they are contributing, they please do so, because we're so grateful, but I don't want to mention your name unless you, and I didn't check with you beforehand to make sure you were comfortable with me mentioning your names.
Someone asked if kids are able to be accepted, so maybe we can just reiterate the age eligibility for everyone again, Dr. Murdoch.
Yeah, so it's 5 to 18. And really, again, that age 5 was based on the ability to tolerate the PET scan to lay flat for that hour and a half. So age 5 to 18, and native aorta, and that's really it.
I see that Wendy Johnson did post that she and her family have been very generous. And I know that Nancy Petrera has donated, and she's on the call too. And I hope I didn't miss somebody else that's donated. Thank you, Wendy and the Johnson family, and Nancy Petrera and her family, in honor of her daughter, Olivia Petrera Cohen. We can't do this research without support, and we've had great funding from the American Heart Association, and we're gonna, once we have this first preclinical study, we're gonna work towards getting the NIH to fund the clinical trial. But we wouldn't, sometimes it takes a year or two to get funding from the NIH, and once we have some evidence that NR will work in the patients, then I want to move on a full clinical trial as quickly as possible. And the ideal situation for getting NIH funding is to launch the trial, and then they get excited about participating, will come in and help fund it. So that's our plan. So, and the full trial will be open to all SMDS patients, not just the limitations for the preclinical testing of the NR that David so nicely described.
Is this only available for US residents? That's one last question.
No, it's available. We have to watch the costs of for the PET imagings, and since we're paying for everything, we need to just watch the cost, but it certainly would be open, and we try to work and get people and make sure we covered airfare.
I think I've pretty much done most of the questions here, and we're just at the hour. So I thought maybe, and I'm putting y'all both on the spot here, but in the last few minutes, maybe you could talk about what you think could happen in the next few years, like and not saying you have a crystal ball and if this is going to work or not, but where do you envision and hope that your research will lead in relation to smooth muscle dysfunction syndrome in the next 3 to 5 years for people living with this condition?
We're hoping in the next 4 months to have the preclinical studies done, that PET imaging, to show the NR is actually working in the SMDS patients, and then launch the full clinical trial after that. And in the meantime, in the laboratory, like I said, we'll be looking more carefully at the lung disease and working with people that are lung experts, specifically Enid Neptune at Johns Hopkins and Mark Sala, who's at Northwestern. I poked Mark into this because he's a cystic fibrosis expert. And in cystic fibrosis, long before they had any treatment, they just managed the lung disease better and more vigorously or rigorously than you do, being more thorough in the way they treat the patients with every single pulmonary infection. And that made a world of difference for cystic fibrosis. So that's what I want to be able to set up the protocol similar to CF, get them on NR, but at the same time, make sure that we're being very aggressive about managing infections, pulmonary infections in the children. So even though if they have a lung problem, it's not making it worse by recurrent pulmonary infections, further damaging the lungs. So look for that within the next year or two. We hope to get out the description of the pulmonary findings, the pathology, and really more detailed methods to, hopefully further delay the onset of pulmonary disease. So the NR treatment, the lung disease, and then we'll see what we get out of treatment of other Moyamoya disease patients. We're making some more mouse models, in particular that RNF213, so we can make sure we can really determine if we can use this therapy for all children with Moyamoya disease. And so I think that's about it. What have I forgotten, David?
No, I think that's everything I wanted to say. I mean, yeah, I mean, I think, getting this initial data, I think will really allow us to move on and expand the trial of NRR into a much, bigger patient cohort. I'm excited to see what the mouse studies in terms of the resolution of existing occlusion, what that shows with NR. So that would be very exciting. So I think I'm cautiously optimistic, that this is going to be a strong benefit to the SMDS patients and others with MMD. So yeah, I mean, I think it's an exciting time, and we're starting to really get some good data, and I'm excited to see what comes in the next year to 2 years. Yeah.
And one last thing that I think I mentioned before is that we have identified other drugs that work, so we'll be pursuing those just in case NR doesn't work, or we think hopefully we'll find a drug that works even better than NR. So
great, thank you both so much. It's really exciting. Everyone's saying thank you in the chat, and I think
yes,
it's exciting. So to reiterate, please do contact Dr. Murdoch at the email addresses he provided, or mac@uth.tmc.edu is also a good way to get in contact with their team if you have questions about the trial, or anything we talked about tonight. Put it out there. You can, I'd be happy to help you. As someone who formally worked on it, please do consider being a part of the registry that she mentioned if you have not already, or your child is not enrolled in that. As she said, that is how all those beautiful recommendations from 2015-16 came out. And if you don't have a copy of those, I would be happy to send you a copy of that paper, which really outlines all of the and is still the only, I believe, only published recommendations for guidelines for this disease. So that is my personal plea to you all. Thanks for spending the evening with us. And this was recorded, as you could all see. So we will be sharing the link to that in case you want to share it with your physicians, care team, family members, and anyone who couldn't join us live tonight. Dr. Milewicz and Dr. Murdoch, if you will press the little door on the bottom to go to the backstage.
Good night, everybody.
Thank you, everyone. Have a good evening.